Welcome to PGOG postgraduate class in obstetrics and gynecology, and today's topic is recurrent pregnancy loss, the current view. It will be a short introduction to the topic. It is defined by Williams as traditionally as greater than or equal to 3 consecutive pregnancy losses of less than 20 weeks or weighing less than 500 grams. Recently, there is a change in definition from greater than or equal to 3 to 2. Any greater than or equal to 2 failed pregnancies can be is defined now as recurrent pregnancy loss. The reason is need to evaluate to find out whether the same constant or the same etiology is responsible for the consecutive losses. One need not wait for 3 to occur. We can start evaluating a patient even after 2 as per the current scientific evidence, and that is why the definition has been changed from 3 to 2. Pregnancy should be confirmed either by ultrasonography or histopathology. Primary RPL is when there is no history of previous live birth, and secondary RPL is when there is a history of previous live birth as per Williams definition, whereas ISHRE guideline says that primary RPL is whenever there is no history of pregnancy going beyond 24 weeks in the previous pregnancy, and secondary is irrespective of the outcome whenever a pregnancy reaches beyond 24 weeks in the past. Now, how RPL is defined by European Guideline 2022 or ISHRE guideline is loss of 2 or more pregnancies where the serum and or urine HCG test is positive. Gestation age should be greater than 6 weeks if the pregnancy is not visualized by ultrasonography. Ectopic and molar pregnancies are excluded. Pregnancy of unknown location is included in the definition of RPL. Spontaneous as well as ART-induced pregnancies are included. Now, whether the definition should include it as consecutive 2 or greater pregnancy losses or even non-consecutive can also be included. Currently, the evidence is not clear. There is a question mark about that because some evidence suggests that we should start evaluating the patient even if there are pregnancy losses, though the losses are non-consecutive. Early RPL is whenever gestational age is less than 10 weeks and there is a pregnancy loss. Now, these definite indications are given by Williams to evaluate a patient of recurrent pregnancy loss. If there is a presence of fetal heart wound and there is an early pregnancy loss, it is a definite indication to start evaluating as we can get a definite and correctable cause also in these cases. If the products of conception in a recurrent pregnancy loss are showing after genetic analysis normal chromosomal pattern, it is also an indication. Age greater than 35 years in the mother and history of infertility. These are the 4 definite indications to start evaluating a woman to know what is the etiology and then accordingly to start treating for recurrent pregnancy loss. Now for students, remember that causes of RPL we can divide in established causes and implicated causes. Established is where there is a definite scientific evidence is present for the link between these factors and RPL, whereas implicated are thought to be of importance, but the scientific evidence has till now has failed to show the definite place in development of RPL. Established are only 3. Remember, genetic, anatomic, and immunologic. In the genetic, there can be a balance translocation in one of the parent, or with the advancing maternal age, there can be defect in oocyte itself. Oocyte can be aneuploid, and that can lead to recurrent pregnancy loss. In the anatomic, uterine structural abnormalities are definite cause for RPL, which can be either congenital or acquired. And in immunologic, we have antiphospholipid antibody syndrome or APLA, leading to thrombotic complications, and it has emerged as a definite cause of recurrent pregnancy loss. Unfortunately, 50% of the RPLs are idiopathic, where in spite of detailed evaluation, we are not able to find out the cause. Now coming to second category, that is implicated but not established, we have first alloimmunopathology. Now autoimmunity, as you know, there are antibodies which are directed and which are acting against our own body's cells. Whereas alloimmunity is there are antibodies which are against the um, tissue from the same species, such as in patients who have an organ transplant, and there can be a problem related to that. Similarly, in pregnancy, it is thought that fetal tissue or the tissue derived from the uh, this male partner component can act as foreign body, and antibodies can develop against these, and that can lead to rejection leading to recurrent pregnancy loss. So that comes under alloimmunopathology. Though it has been implicated, it has not been established beyond doubt. In inherited thrombophilias, factor V laden mutation is one example, which have also been thought to be the cause, which are thought to be the cause but not proven beyond doubt. Endocrinopathy is also considered as likely cause of RPL, but not proven beyond doubt. Genital mycoplasma is also in similar category, and smoking, heavy alcohol consumption, caffeine consumption also is implicated, but not proven beyond doubt as a cause for recurrence of pregnancy loss. Now, one by one, we'll start looking at the uh, causes of RPL. First is a genetic cause, which comes under the definite cause of RPL. Now, it has been seen that in 75% of spontaneous early abortions, there is a genetic cause. And whenever there is a genetic cause, in 90%, there is a numerical abnormality such as polyploidy or aneuploidy responsible for abortion. In remaining 10%, there can be structural problems such as translocations or inversion, or there can be mosaicism. Genetic cause is more commonly seen in sporadic abortions than in young women with recurrent pregnancy loss, especially whenever the age is less than 35 years. Whenever the mother's age is beyond 35 years, then the genetic cause is responsible in the same manner for sporadic as well as for recurrent pregnancy loss. Most common genetic cause is autosomal trisomy followed by monosomy, that is 45XO. Genetic techniques for analysis of products of conception. Karyotyping can be done, but it is associated with high maternal contamination, and so it is not recommended currently. Fish or fluorescence in situ hybridization has got a limited place because it based only certain chromosomes. What is considered better at present and recommended is array CGS. Array CGS is array-based comparative genomic hybridization. It is a preferred technique, but disadvantage is it may identify clinically relevant findings. So for students, if you are asked which is the best technique, current technique by which we can do the genetic testing of products of conception, your answer should be array comparative genomic hybridization or array CGH. Now, what is the value of genetic testing of products of conception in RPL? Because nowadays we do get educated patients who themselves are sometimes demanding that whenever they have abortion, they are asking us why not do the testing of the fetus to know whether there is any chromosomal abnormality. So for that, aneuploidy, that is either there can be a genetic abnormality in the ovum, sperm or embryo. Aneuploidy can lead to early sporadic pregnancy loss, or it can lead to recurrent pregnancy loss. So it is not that it will lead to always only to recurrent. Sometimes it leads to sporadic, that means one abortion and then it is followed by a normal pregnancy in many women. And it is nature's way of eliminating abnormal this birth of abnormal individuals. Now, whenever we do the genetic testing of products of conception, it helps us in counseling, but it does not rule out other causes of RPL, as it can be one of the contributing factor. There can still be presence of other causes. It does not help in prognosis. It does not help in planning the treatment in cases of recurrent pregnancy loss. This should be included in counseling whenever we consider sending products of conception for genetic testing. That it helps in knowing whether that pregnancy itself was because of the chromosomal abnormality. That does not mean that next will also be because it is a cause of sporadic pregnancy loss in many cases. So it does not help us in prognosis, it does not help us in planning treatment. So it has a limited value. If normal genetic testing report comes, then it needs definite evaluation for other causes of RPL. That is the advantage. That when we send the tissue products of conception for genetic testing and report comes normal, on the other hand, it is a definite indication to start evaluating for other causes of recurrent pregnancy loss. Now, in parental causes, there can be balanced translocation, which can be responsible for RPL, but it is responsible for RPL in less than 5%. It is not a common cause of recurrent pregnancy loss. Balanced translocation in either of the parent. Now, this testing is indicated even in non-consecutive losses also. Reason is, whenever there is a balanced translocation, transmission to the fetus can be as balanced translocation itself, so the baby will be normal. Or baby might have an absolutely normal chromosomal analysis, so baby will be normal. And in remaining 50%, there can be a problem of imbalance of the translocation leading to chromosomal abnormality and pregnancy loss. So one pregnancy might be normal, another might be abortion, again one might be normal. Like that, history can be there of non-consecutive losses. And so in non-consecutive losses, this balanced translocation in one of the parents can be a possibility. With increasing maternal age, there is a decrease in the ovarian reserve, and it is associated with increased possibility of having unexplained recurrent pregnancy loss. Tests for ovarian reserve are indicated whenever there is a unexplained recurrent pregnancy loss. Now, treatment, whenever we identify that there is a balanced translocation in one of the parent, is pre-implantation genetic testing is done in IVF, and then normal embryo is implanted. But one word of caution is, though we do pre-implantation genetic testing, there is no increase in live births with PGT. So it has, in that way, it has a limited. Though the baby might be chromosomally normal, still there can be other complications in second or third trimester leading to pregnancy loss. Coming to anatomic causes, there can be congenital malformations of uterus, or there can be uterine leiomyomas, or there can be presence of intrauterine adhesions. How we evaluate is either by hysterosalpingography, transvaginal sonography, or sonohysterography. So out of all these, TVS and sonohysterography are better than hysterosalpingography to evaluate the anatomic cause in recurrent pregnancy loss. These both TVS and sonohysterography, they assess external uterine contour, and that is how they help in diagnosis of either septate or bicoordinate uterus. Sonohysterography is better for intracavitary lesions, such as to identify whether there is submucous fibroid or endometrial polyp, or whether there are intrauterine adhesions. 3D transvaginal sonography has got a good specificity and sensitivity, and it is as good as doing a sonohysterography. MRI or 3D TVS it helps to differentiate between septate and bicoordinate uterus whenever there is a doubt with the 2D ultrasonography, or there is a doubt with the sonohysterography. Laparoscopy and hysteroscopy, endoscopies can be required in few cases where it will help in confirmation as well as it will help in treatment, such as septum resection or excision of submucous fibroid or endometrial polyp. In congenital malformations, there is a long list is there, and unicornate uterus, there is no treatment required for the correction of this, or we can't do anything to increase the capacity of a unicornate uterus, but cervical encirclage can improve the pregnancy success rate whenever there is a history of second trimester recurrent pregnancy losses. Uterine diadelphys is usually no surgery is recommended. Rarely uterine unification might help in recurrent pregnancy loss. And in that case, though we unite the two uteri, The cervixes are to be kept as it is. We don't unite the cervixes. Bicornuate uterus, the current terminology is bicorporeal uterus. Here, Strassman abdominal unification is in rare selected cases only indicated. Otherwise, even in these cases also, surgery does not improve the pregnancy outcome in RPL. This is bicornuate or bicorporeal uterus is a commonest cause of associated cervical incontinence, and so cerclage is indicated. That we have to remember. Now, septate uterus is the only anomaly which is not associated with urinary abnormalities. Otherwise, all these unicornuate, diadelphys, bicornuate, these are associated with, might be associated with urinary, and we need to evaluate the urinary tract to see whether there are any urinary tract congenital malformations. Septate uterus is the only one where we don't have these urinary anomalies because the septum gets dissolved after complete development of urinary tract. This is the most common anomaly with recurrent pregnancy loss, and hysteroscopic septoplasty is indicated in these cases, and it has the evidence shows a definite place that it improves place in our treatment of RPL by improving the successful pregnancy rate. Uterine leiomyomas can lead to recurrent pregnancy loss because of the poor blood flow, normal vasculature, or inadequate decidual formation. Myoma, if it is not distorting the cavity, then it is not an indication for myomectomy. That this is like, we have to remember this as a principle, that any leiomyoma which is not distorting the cavity, which is not encroaching on the uterine cavity, endometrial cavity, then we should not be touching it. Hysteroscopic myomectomy can be done, or if it is a large fibroid, then even combination of hysteroscope and abdominal myomectomy might be required whenever it distorts the endometrial cavity. Meescherman syndrome or uterine adhesions in RPL mechanism is they reduce the uterine volume, and these adhesions also lead to placental insufficiency because of endometrial fibrosis and endometritis. Whenever curettage is done for in a case of abortion, then it can lead to adhesion formation. It leads to abortion in 40 to 80% of the cases. If you diagnose patient as uterine adhesion, then the chances of women going for abortion, it is in 40 to 80%, as high as that with the uterine adhesions. Adhesiolysis improves prognosis in 50 to 90% of the cases. Now, why only in 50 and why not in remaining 50 is because recurrence of adhesions is very, very common. Hysteroscopy is better than blind curettage, but one needs to take additional measures to prevent recurrence of adhesions. Now, in the immunological causes, we have autoimmune and alloimmune factors. Autoimmune antibodies are against cells. Alloimmune are against fetal or paternally derived placental cells. In this autoimmune, we have three antibodies. One is this systemic lupus erythematosus, SLE, where the antibody, again antibody is same, APLA in SLE also. It usually leads to second and third trimester loss. Whereas APLA is antiphospholipid antibody. These are responsible for less number of RPL cases, only 3 to 5%. But once identified, it emerges as the definite cause which even responds to proper treatment. Treatment is same for SLE as well as for APLA-induced recurrent abortions. Now, third antibody, autoimmune antibody presence, which can lead to recurrent pregnancy loss, is anti-thyroid antibody. In the alloimmune, we have either there can be cytotoxic antibodies, or there can be absence of blocking antibodies, or NK cell dysfunction can be there. These are the three mechanisms which are thought to be responsible for this development of alloimmune factors for recurrent pregnancy loss. Cytotoxic antibodies, absence of blocking antibodies, or NK cell dysfunction, natural killer cell dysfunction. Now, diagnosis of Aplar syndrome, it is based on presence of either one of the clinical criteria and one of the lab criteria. In clinical criteria, vascular thrombosis is first, greater than or equal to one pregnancy loss of greater than 10 weeks, where the fetus is morphologically normal. Then also it is sufficient to have consider it as a clinical criteria. If there is greater than or equal to one preterm birth because of preeclampsia, eclampsia, or because of placental insufficiency, or greater than or equal to 3 consecutive unexplained early recurrent pregnancy losses. So these are the 4 criteria, clinical criteria. Anyone should be fulfilled to diagnose APLA along with any one of lab criteria. In lab, either there can be positive lupus anticoagulant antibody, which should be positive for at least 2 times with an interval of minimum 12 weeks in between. Similarly, greater than 2 times 12 weeks apart, anticardiolipin antibody IgG IgM with a titer which should be medium to high. Or there can be positivity of anti-beta-2 glycoprotein 1 antibody, same way, greater than 2 times 12 weeks apart. It can be either IgG IgM with 99th percentile. So these are the specific criteria, lab criteria to diagnose this antiphospholipid antibody syndrome, and I think students will have to memorize this, because if it is you diagnose it and you treat it, the prognosis improves dramatically. Treatment in patients who are having recurrent pregnancy loss and positive Aplar syndrome is, now it is responsible for 3 to 5%, but it is a treatable cause. That is why it is very important to test the any patient with RPL for this. What is to be done is aspirin to be started with a dose of 75 to 85 milligram per day from pregnancy planning itself. So you don't wait for the pregnancy to be diagnosed to start aspirin. You start aspirin whenever pregnancy is being planned. With that, heparin is to be given whenever the pregnancy is diagnosed. Now you can give either unfractionated heparin with a dose of 5,000 to 10,000 units twice daily, or we can give low molecular weight heparin. LMWH is slightly expensive as compared to unfractionated heparin, but it is safer because the bleeding episodes or complications are less. Thrombocytopenia, osteopenia is less with this as compared to unfractionated heparin. Prednisone was tried, but it leads to it increases the risk of diabetes, hypertension, preterm delivery during pregnancy, and that is why risk is more as compared to benefits, and it is not recommended in Aplar syndrome with RPL. IV immunoglobulin G is indicated whenever there is a secondary recurrent pregnancy loss with Aplar. Secondary is whenever there is a previous history of pregnancy going beyond 24 weeks of gestation. In these women, there is a specific place has been seen by these randomized control trials that it improves the pregnancy outcome whenever we use IV immunoglobulin G. Now, third is antithyroid antibody presence as autoimmune cause. Now, in these cases, there is no role of giving thyroxine supplementation. Though antithyroid peroxidase antibody detection is there and presence is detected, still we should not be starting the patient on thyroxine supplementation. No treatment is recommended, but we need to carefully and frequently monitor the patient by doing TSH, as this raised antibody titer might show hypothyroidism in late pregnancy. Postpartum monitoring is also necessary because it can lead to postpartum thyroiditis. In autoimmune medicated recurrent pregnancy loss, there is no diagnostic test available. It is assumed to be present in unexplained RTL. Treatment with immunostimulation by paternal leukocyte immunization was tried. The studies are showing there is no specific benefit, and that is why currently it is not recommended. Paternal leukocyte immunization. IV immunoglobulins are pulled from 150 donors, and there is always a risk of infection, transmission, and anaphylaxis with these IV immunoglobulins. And there is no current evidence showing benefit in unexplained recurrent pregnancy loss, and that is why it is not recommended. This IV immunoglobulin. It is important because so many times we see the patients coming to us with the prescriptions with a history of RPL, which includes a cocktail of whatever we can use, such as progesterone, SCG, along with that vitamin D, folic acid. That is okay. Vitamin D, folic acid is not going to harm. But along with that, heparin, aspirin unindicated is also initiated, and even IV immunoglobulins are also given. But remember that there is a risk of infection, transmission, and anaphylaxis, and that is why we need to be cautious whenever we give it empirically. This is not the drug which should be given empirically. Now, in implicated but not established causes in inherited thrombophilias, testing is not recommended as a routine in RPL. Only in high risk cases only we should be doing testing for factor V laden mutation or protein C resistance in unexplained RPL can be done in selected cases whenever there is a pregnancy loss after fetal heart sound detection. Heparin has got a questionable but a possible role whenever there is a positive test for this, but aspirin is not recommended. In endocardiomyopathies, hypothyroidism has got a comparatively clearer role for the development of RPL. We need to keep TSH level less than 2.5 milliunits per ml in first trimester and less than 3 milliunits per ml in second and third trimester. Students should remember these values. So we have to adjust the supplementation, this thyroxine supplementation accordingly. Diabetes should be ruled out by HbA1c and blood glucose whenever it is suspected, but usually it is not a cause for recurrent pregnancy loss. If there is a PCOS and it is thought to be leading to RPL, letrozole-induced pregnancy are showing better success rate as compared to clomiphene, and we can add metformin along with letrozole. LPD, luteal phase defect, clomiphene, again the treatment is to give clomiphene for induction of ovulation, which will lead to successful pregnancy. Post-ovulation progesterone is currently not recommended because it leads to delayed menses, and there is additional anxiety in patients who already are having problems with recurrent pregnancy loss, and it is better to avoid this. So better treatment for luteal phase defect is clomiphene induction rather than giving progesterone after ovulation. And we need to detect and treat hyperprolactinemia if there is a presence of galacturia. Now for infections, doing culture is sensitivity testing is not cost effective, and that is why empirical antibiotic treatment is recommended for 2 weeks in patient with RPL. Either azithromycin can be given, erythromycin can be given, or doxycycline can be given empirically. Cessation of smoking is recommended. Alcohol not greater than 2 drinks per day, caffeine not greater than 300 milligram per day. So restriction for alcohol consumption and caffeine consumption, and if there is obesity, it needs to be controlled. Unexplained RPL is responsible for 50% of the cases. Emotional support plays an important role. Counseling should be done about good prognosis in spite of having 2 or 3 losses. No role of empirical treatment in unexplained RPL, such as, again I am repeating, empirical treatment should not be given, such as aspirin, heparin, progesterone, or immunoglobulins. Now, summary of investigations: definite places, APLA testing, parental karyotyping in selected cases, TSH and thyroid peroxide antibody testing, 3D transvaginal sonography, and if it is not available, this sonohysterography can be done as a second test second line or second choice of investigation, even that is not there, then we can go for HSG. And SOS, we can go for MRI if there is a doubt about diagnosis. Urinary tract evaluation should always be done with congenital malformations, except with one anomaly, that is septate uterus. Questionable place of these investigations in case of RPL. First is genetic testing of products of conception by array-based comparative genomic hybridization. It has a questionable place, as we have already seen. It does not help us in prognosis or treatment. Hereditary thrombophilia, not as a investigation for that, should not be done as a routine. Only if there is a positive history of thrombosis or high risk case, then only it should be done. HLA antibody testing or other tests for alloimmunity are not recommended in a case of recurrent pregnancy loss. PCOS, LPD, prolactin testing is not recommended as a routine. Only if there is a positive feature, associated feature, then only it can be done. Sperm DNA fragmentation testing can be done. It has emerged as a question, though questionable, it has emerged as an investigation in RPA. Now for definite causes, we have genetic cause, where we can go for parental testing. Product of conception testing has a questionable place. Sperm DNA fragmentation testing can be done. To know whether there is an anatomical cause, 3D transvaginal sonography is best. Now, if it is not available, second choice of investigation is sonohistography. That is also not available. We can go for hysterosalpingography. And SOS, MRI to be done in if there is a doubt with these investigations. Immunological causes, autoimmune causes, we have APLA, for which we have to go for this lupus antibody testing, anti-cardiolipin antibody testing, and antibody against beta-2 glycoprotein 1. For implicated causes, testing for autoimmune factors is not indicated. Hereditary thrombophilia testing as a routine is not indicated. In endocrinopathies, mainly TSH and this thyroid peroxidase antibody testing is indicated. Otherwise, if features are not there, testing for other endocrinopathies does not help in improving the prognosis. Summary of treatment in RPL. For definite causes, if there is a genetic cause such as balanced translocation in either of the parents, then this PGT with IVF will help, that is pre-implantation genetic testing. Or we can go for donor ovum or sperm. In anatomic causes, only anomaly which has definitely shown a scientifically improvement in success rate is septate uterus, where hysteroscopic septoplasty plays a major role. In all the others, surgery has got a questionable place, to be done in selected cases only, and cerclage to be done whenever there is a history of or evidence of cervical insufficiency. Leiomyoma and polyp, if it is distorting the cavity, then only it should be touched, myomectomy to be done, otherwise there is a questionable place. For intrauterine adhesions also, question mark is given for a hysteroscopic adhesive lysis because of the high chances of recurrence of adhesions. For implicated causes, endocrinopathies, in hypothyroidism, whenever it is a clinical hypothyroidism, there is a definite place to give levothyroxine. If it is subclinical, there is a questionable place for supplementation with thyroxine. If patient is euthyroid and presence of thyroid peroxidase antibodies are there, it is not an indication to give thyroxine supplementation. Luteal phase defect, progesterone supplementation has a questionable place. Even HCG supplementation also has a questionable place. It has not been proven that it improves the success rate. If patient has diabetes, questionable place as a routine inclusion in a patient of recurrent pregnancy loss with diabetes. If it is unexplained recurrent pregnancy loss and greater than or equal to 4 RPL, which are unexplained, then there is what has emerged currently is intravenous immunoglobulin. If it is given repeatedly from early pregnancy in a high dose, it has shown that it improves the prognosis. So immunoglobulin is indicated if greater than or equal to 4 recurrent pregnancy losses which are unexplained. Vaginal progesterone is indicated if there are greater than or equal to 3 recurrent pregnancy losses. Intralipid therapy, though has been tried, it has not been proven to be of any help, and scientifically it has not shown to be of improving the success rate in recurrent pregnancy loss. Thank you. These are the references. Spear of 2019, ISHRI guideline 2023, Williams Obstetrics 26 edition. I think recurrent pregnancy loss for students, though you might get it as a case in your practical examination, the do's are less, definite causes are less, the treatable causes are less. What not to do is more. Because what we see is so many times patients are being investigated unnecessarily. Expensive investigations are done which do not improve the uh, success or do not improve the prognosis, and even the treatment also so many times dangerous drugs are given as empirical treatment which needs to be avoided. That is the take home message. Thank you once again.